Hello, everyone, and welcome to today's AC Forum webinar. Excited to talk with the folks that we have here for you. We'll be discussing emerging anticoagulants and reversal agents. What's next in the pipeline? Next slide. And this particular webinar actually is accredited for an hour of CE. So make sure that you claim your credit after this. After we get done here, the information is on the screen of how to do that. Next slide. I'd like to introduce our panel today. My name is Arthur Allen. I'm an anticoagulation program manager and clinical pharmacy specialist at the VA hospital in Salt Lake City. I have with me my co-moderator, Jory May, an assistant professor in the Department of Medicine and the Division of Hematology and Oncology at the University of Alabama at Birmingham. Have Jeff Barnes as one of our presenters today, the current president of the Anticoagulation Forum and an associate professor at the University of Michigan. We also have presenting today Gabe Fontaine, a clinical pharmacy manager of critical care, emergency medicine, and telecritical care, and associate professor of neurosciences and critical care medicine at Intermountain Health here in Salt Lake City. And we have Gene Connors as a panelist, medical director of the Hemostatic and Antithrombotic Stewardship, medical director, Anticoagulation Management Services Hematology Division at Brigham and Women's and Dana-Farber Cancer Institute, and a professor of medicine at Harvard. So at this point, we'll go to the next slide and I'll hand it over to Dr. Barnes. Thank you.
Well, thanks, Arthur. I really appreciate it. And I'm really excited to talk with everyone today about emerging approaches to oral anticoagulant therapy, some that you've probably heard of and maybe a couple that you haven't heard of, and just wet the whistle a little bit for what may be coming down the pike in the next couple years. These are my disclosures, and they largely relate to the companies that make current and some of the future anticoagulant medications, as well as serving on the AC Forum board. As always, I love to start with a case. And so let's frame our discussion around this 75-year-old gentleman. He has stage 4 chronic kidney disease, type 2 diabetes, and atrial fibrillation. And he's coming into clinic for a routine follow-up. As you review his chart, you realize that he's still using warfarin and he has that very typical INR goal of 2 to 3. But as you go and you review his success with warfarin, you notice that his time in therapeutic range over the last year or so has been about 55%. And notably, he's had several labile INRs, some going high, some going low, things like that. And in fact, as you talk to him, you find out that he's had a history of some nosebleeds. He complains of some pretty easy bruising, and that sort of opens up a conversation about what other options may exist. And so while we know a lot about the direct oral anticoagulants, and we've been using them for well over a decade, this sort of case also brings to mind, well, what alternatives do we have for effective stroke prevention in AFib that could help minimize bleeding risk? And especially what options perhaps go beyond the direct oral anticoagulants. And so that's how I want to sort of frame the next 20 or 25 minutes of conversation. You know, we've been talking here recently about this holy grail of separating out hemostasis from thrombosis. Thrombosis is the thing we want to prevent, right? That's the pathologic clot that occurs inside a blood vessel. It can lead to a stroke, can lead to a myocardial infarction. It can lead to a deep vein thrombosis or a pulmonary embolism. That's something we absolutely want to prevent with the use of our oral anticoagulants. At the same time, we want to allow hemostasis to occur as normally as possible, meaning anytime there's some injury to a blood vessel wall, we want to be able to plug that up so that we don't exsanguinate, so we don't bleed or have significant bruising. And if you look at a sort of simplified version of the clotting cascade, you can start to get a sense for how these two might be a little bit different. On the left side of the screen, you see what's called the tissue factor pathway. Anytime a vessel wall is damaged, it exposes tissue factor, which then activates along with factor 7 through the common pathway, which is shown in purple, to help form fibrin scaffolds, and that's where we get our hemostatic plug to occur. On the right side in blue, we see the contact pathway really started up with factors 11 and 12, going through factor 9 and factor 8 to also activate that common pathway in purple. And in this case, we often see that this leads to larger thrombotic events, things that are more thrombosis related, like a MI, heart attack, stroke. And in fact, if we think about our currently available oral anticoagulants, they tend to hit either all elements, as in the vitamin K antagonists, which touch on both of the two arms and the central pathway or the common pathway, or we have these direct oral anticoagulants, which specifically target factor 10 or factor 2, also known as thrombin. But the holy grail would really be for separating it out. Is there a way we could prevent that contact pathway through inhibiting something like factor 11 so that we don't develop thrombosis, but allow the tissue factor pathway to stay intact? So if there's any damage to a blood vessel, we can quickly form that hemostatic plug to prevent the bruising and bleeding that is so problematic. This is a particularly exciting hypothesis because we know that thrombin actually feeds back into factor 11 in something that's called the thrombin amplification loop. And we think that likely plays a role into how this clot ends up forming in a larger manner. And so by inhibiting factor 11, we might be able to break that thrombin amplification loop. Now, there's some really good justification for this hypothesis. In fact, there are many patients out there who are congenitally deficient in factor 11. You'll sometimes hear them referred to as having hemophilia C. And when we've studied them epidemiologically, we've actually been able to show that they have lower rates of thrombotic events than folks who have normal factor 11 levels. In the case of stroke and MI, we're looking at about a 40 to 50% lower incidence. And for venous thromboembolism, it could be even 70 or 75% lower. Yet many of these patients don't present until later in life because they don't really have bleeding complications the way we think of with the more traditional hemophilias like hemophilia A and B. And so this really feeds into this notion that we might be able to prevent thrombosis while leaving hemostasis intact. Now, how would we go about doing this with different agents? Well, the way that most clearly mimics congenital factor 11 deficiency would be to shut down production of factor 11 in the liver. And that can be done with an antisense oligonucleotide, or an ASO. Now, when you administer this medicine, it can take a long time for that to have effect because you're stopping production of a clotting factor. But once you shut it down, it lasts for a long time, often for many, many weeks. The next option is to use a monoclonal antibody to bind up factor 11 or factor 11A. This has a much more rapid onset after you give the medication, but that binding really holds tight, so the effect can also last for days or even weeks, allowing you to dose this medication maybe every couple weeks or even once a month. And then, of course, the third way is the way most of us are familiar with using anticoagulant medications, which is to use a small molecule inhibitor. This, again, is a very rapid onset medication. You take it, and it's usually effective within a couple hours, but it's also going to wear out over the course of several hours. So you usually need to dose these medicines once or twice a day. Now, there are 3 of these agents that have progressed all the way into phase 3 studies. One of them is a monoclonal antibody that's called abelacimab, and it's currently being dosed once a month. The other 2 are small molecule inhibitors. Asundexian is currently being dosed once a day, and milvexian is being dosed twice a day. So we have 3 exciting agents that have progressed all the way into phase 3 studies and that we're hoping to learn more about here in the next few years. Let's dive into some of the data behind them. As with any anticoagulant, we often will start with phase 2 studies in knee arthroplasty patients. That's because these are patients who often develop DVT and something that we can easily identify. Several of these phase 2 knee arthroplasty studies were done. I put in bold the 2 that have actually progressed now into the phase 3 studies, abelacimab or monoclonal antibody, and milvexian, one of those small molecule inhibitors. And in the top grouping, you can see the effect for preventing DVT. And you can see that all those triangles are sort of on the left side of that line of unity, meaning that the prevention of VTE was better with the factor 11 inhibitor than it was with low molecular weight heparin. But what's really exciting is the bottom half where you see that bleeding icon. These are for the bleeding outcomes. We also see that shifted to the left side of unity, meaning there was less bleeding overall than when we compared it to low molecular weight heparin. And I've highlighted the sort of summary statistics here for you as well. So as a class, we're seeing both efficacy and safety demonstrated in a phase 2 study. But note that there isn't actually a study of asundexian that was done here, and that'll probably come back as being important in just a few minutes. Now, if we zoom out and we look at all of the phase 2 studies that have been completed as of late last year, what you can see is really some remarkable success. Whether you're looking at the first column of the antisense oligonucleotides, the middle column of the monoclonal antibodies, or the right column of the small molecule inhibitors, overall you see good data showing either similar or better outcomes across a number of different disease states. Knee arthroplasty, atrial fibrillation, acute MI, secondary stroke prevention, and even end-stage renal disease. So all of this phase 2 data has us really excited about what the potential could be in a much larger phase 3 study. Let's dive into one of those phase 2 studies in particular. This was the Azalea TIMI 71 study. This was a study of patients who had atrial fibrillation, and they were randomized to one of 3 different arms. 2 of the arms had the intervention drug abelacimab. That was that monoclonal antibody that we talked about. They tested 2 different doses, each given once a month, and they compared it against rivaroxaban 20 milligrams once a day. That's sort of your standard stroke preventative DOAC therapy. Now, again, this is a phase 2 study, meaning that the primary outcome here was for bleeding, and then secondarily, they looked at the stroke and systemic embolism rates. And the primary outcome was really good. In fact, they stopped this study early because there was so much less bleeding in the abelacimab data. Look at this. The gray line represents the rivaroxaban group, and the 2 shades of blue represent the abelacimab group. We see an over 60% reduction in major or clinically relevant non-major bleeding in the folks who received the factor 11A inhibitor abelacimab as compared to rivaroxaban. But what's even more exciting for me is that they said, this is a medicine dosed once a month. What happens when people need to have procedures done? And so they presented some data looking at the rate of peri-procedural bleeding. In purple, you can see the rivaroxaban number, about 2.2%. And in orange, you see the pooled abelacimab data, 1.2%. Now, that didn't have a statistically significant reduction in the risk ratio, but it certainly is trending that way, which is very exciting. But even if you said, well, what about only the cases where they had surgery within the first 30 days? So we know the abelacimab's fully on board. That's that sort of peach color all the way to the right, really low rates of bleeding. So really some exciting data to suggest, yes, this hypothesis of preserving hemostasis is likely maintained in a phase 2 study like this. Now, we want to look cautiously at the thrombotic events. This study was not powered to look at stroke or systemic embolism, but if you just look at the numerical numbers, you do see that the abelacimab arms had numerically higher rates of stroke and systemic embolism than the rivaroxaban arm. But still, we're going to need to look at the phase 3 studies to get a much better understanding of how much efficacy is really there with these factor 11 inhibitors. In fact, let's look at the first and to date, the only completed phase 3 study. This was called the Oceanic AF trial. This was a trial of patients who were treated for atrial fibrillation, and they randomized them. Half of them got asundexian, that's the investigative small molecule inhibitor, 50 milligrams once a day. The other half of patients were randomized to receive apixaban at your standard AFib dosing, 5 milligrams twice a day. Now, again, this is a phase 3 study, much larger sample size, and in this case, they're powered for stroke or systemic embolism, and then secondarily looking at the bleeding events. Unfortunately, this trial also was stopped early, but it was stopped early because of a lack of efficacy. On the left-hand side of the screen, I'm showing you the stroke or systemic embolism cumulative incidence curve. And what you can see is that the yellow line, that's the asundexian line, had a higher cumulative incidence out to 1 year of stroke or systemic embolism than the apixaban line, which is the one shown in blue. Now, from a safety standpoint, we did get some reassuring data. Asundexian had less bleeding than apixaban, shown on the right-hand side of the screen. So that certainly was preserved. But in this case, we can't say that asundexian at 50 milligrams once a day was efficacious for the prevention of stroke in patients with AFib, at least in this trial population. And some people have asked why. Why might that be the case? And one thing a lot of folks have centered on is, was there enough inhibition of factor 11? Well, if we look at the phase 2 study of asundexian in AFib patients, that was called the Pacific AF trial. They used a special measure that looked at the ratio of factor 11 activity here, and they looked to see what was the ratio of reduction at trough and peak values. And they got 92 to 94%. And you would think that's normally pretty good. However, if you go back to that Azalea study, remember that was the monoclonal antibody abelacimab, also in AFib. In this case, they actually got free factor 11 activity inhibition around 98 to 99%. Now, these are two different ways of measuring factor 11. They're not interchangeable, so you can't compare 92 versus 98%, but it does give you a sense that maybe there's an opportunity for additional factor 11 inhibition, especially when the Azalea trial had such good safety data from a bleeding standpoint. Now, where do we currently stand with all of these drugs? There are several ongoing phase 3 studies, and let's go through each of them one at a time. For abelacimab, which is our monoclonal antibody, there is the LILAC-TIMIDI-76 trial. This is a trial comparing abelacimab to placebo in patients who have AFib but are deemed not to be a candidate for oral anticoagulation. So really asking whether adding abelacimab on top of their other medical therapy could help to prevent stroke without increasing bleeding in an already high bleeding risk population. Abelacimab is also being studied in two different cancer-associated VTE studies. The first is called the ASTER trial. This is comparing abelacimab to apixaban in cancer-associated VTE. But they also have the Magnolia trial, which is looking at abelacimab versus low molecular weight heparin in patients whose cancer-associated VTE is associated with a GI cancer, the ones where we're most concerned about bleeding from an oral anticoagulant. So 3 different studies using the monoclonal antibody, lots of exciting data yet to come. Now, how about those small molecule inhibitors we talked about? Well, there are several ongoing studies there as well. From an AFib standpoint, we just talked about the oceanic AFib trial that had to be stopped. Well, there's the Librexia AFib trial, and that one has continued and has passed at least one, if not several, of the DSMB checks. This one's looking at milvexian, which is the other small molecule inhibitor, 100 milligrams twice a day, and comparing it to apixaban in an AFib population. Now, they're also looking at a population of patients with secondary stroke, meaning that they've had a stroke, but there was no AFib associated with it. And can we try to prevent future stroke events? There are actually 2 studies in this case, one using milvexian, which is called the Librexia stroke study, and the other using asundexian, called the Oceanic stroke study. And you can see both of them are being compared versus placebo, in addition to the other medical therapy that usually would be given. So some exciting data. And in fact, I've heard that we may even get some data within the next year on some of these 2 studies. So really exciting things to keep your eyes out for. And then the last one is actually a study of patients with acute coronary syndrome. There's a study called Librexia ACS, which is looking at a low dose of milvexian twice a day versus placebo, in addition to the usual antithrombotics that patients who undergo acute coronary syndrome receive. And they're looking to see whether you can prevent future major cardiovascular events. So really a number of different studies in several different therapeutic areas, some that are a little newer to us as anticoagulant providers that we're going to need to keep our eyes on. And I think we could start getting data even as soon as within the next year. But what about other approaches? You know, we talked about the factor 11 inhibitors. There's a lot going on. What if we go back to the idea of vitamin K antagonists? Are there ways we could improve on the VKAs? Well, one of them that has been looked at here over the last several years is a drug called ticagrelor. This is a very similar vitamin K antagonist to warfarin, but it has a couple very important distinct properties. It's still measured using an INR just like warfarin is, but its metabolism is different such that there's actually minimal impact with chronic kidney disease. So this could potentially be a really nice option for folks who have more advanced forms of renal dysfunction. Also, it has many fewer food and drug interactions than warfarin does. So there may be an opportunity to have a more stable agent. In fact, this drug has actually already been tested in one randomized trial comparing it against warfarin. This is almost a decade old now, but they took patients, most of whom were warfarin experienced, but some who were warfarin naive, and they randomized them to receive either warfarin or ticagrelor. Now, in this particular study, what they saw was that the number of INRs drawn every month was the same in the two groups, and the time and therapeutic range was the same in two groups. So we didn't get a big win, but certainly we showed that there was some similarity in certain kinds of clinical outcomes that we care about. I think there's a lot more that we could learn, figuring out where this drug might have a home and understanding whether it's going to be efficacious and safe. Those are some really exciting questions to be asked. But what if you say, look, I know warfarin, warfarin's been the drug for me for a long time. Is there a way we could improve upon warfarin? And this is where a really interesting question came up, which is to say, is the pro-time version of an INR really the best way for us to be measuring warfarin? I'm going to take you back to that simplified coagulation cascade that we started out with and just remind you that when we're measuring a PT or an INR, we're sort of measuring that tissue factor pathway all the way down, including, factor 7, we've got factor 10, factor 2, all of those being measured using the PT-INR. The problem is that factor 7 has a much shorter half-life than the other clotting factors, which means that it can be much more variable and susceptible to changes. This is really important when we're first starting warfarin, but certainly if anything changes, a dose change, maybe a new medication that somebody takes, a change in their diet, you can see fluctuations in factor 7, which will impact the PT-INR in a way that may not fully represent the effect of warfarin. And so some really thoughtful clinician scientists out of Iceland have been thinking about ways to get a more stable and reliable measure, something that's called the FIX, or the factor 2 in 10, which is a different version of an INR that's focused just on those longer half-life, really more stable factors of factors 2 and 10. In fact, they've been studying this for over a decade, and they've got some really great data to show. This is data that looks at how they've implemented it within their region in Iceland. And what they did is they initially had patients on the standard PT-INR. That's the left side of the graph. And they're plotting here on your y-axis the thromboembolism incidence. So how likely people were to develop a clot. They then had about a 6-month transition period as they transitioned everyone over to using this FIX INR. So instead of using the standard PT, they're now only measuring factors 2 and 10 and converting that into an INR. And then after that, they continued to follow those patients. And what you can see with that red line is once they started the transition and continuing through the full utilization period of the FIX, the rate of thromboembolism decreased. In fact, they cited a 56% reduction in thromboembolism risk. That's pretty exciting. From a bleeding standpoint, they did not see any harm. In fact, the rates of bleeding looked pretty similar in both the pre-transition and post-implementation periods. And really hot off the press, they also were able to show, because of the stability, they were actually able to reduce the frequency of INR testings by about 24%, meaning 24% fewer INRs and blood draws for people to get, and that much less work for their clinic staff to have to manage. So really some potential wins from a healthcare utilization standpoint. Now, hot off the press, they just compared their observational data with the FIX warfarin management to not just the standard PT-INR warfarin management, but also to various DOACs. And so on the left side of the screen here, I'm showing you the cumulative rate of thromboembolism over time, and the yellow line is the line showing the FIX INR. Compare that to the purple, which is the standard PT-INR, and all the other colors, which are your various direct oral anticoagulants. And you can see there's a reduction in the thromboembolism rate with the patients who were on the FIX version of the INR managed warfarin. They were also able to show a reduction in the number of tests when they compared it to the PT version. In the middle graph here, you can see the wider the gray box, the more of the patients who fell at that level. And so on the left is the standard PT-INR and the right is the FIX. And we can see that the FIX has that sort of shifted down, and the red line represents the median number, so fewer number of tests per year. And to get that on the right, we see the number of days between tests. They were able to go from just under 30 to about 35. So you can actually go a longer period of time between testing because the patients ended up being so stable. So some really exciting ways that we could think about improving our current use of warfarin, as well as some alternative agents. So if we return to our case, remember this was the 75-year-old man. He had chronic kidney disease, diabetes, and AFib. His INR has been particularly difficult to control. We all know that we could be thinking about a direct oral anticoagulant, and in many cases, that's a good option. But with his stage 4 chronic kidney disease, what other items might be out there on the horizon? Well, we've talked a lot about factor 11 and factor 11 inhibitors, both the small molecules and the monoclonal antibodies. And I think we're going to start getting some data here within the next year to see whether or not these are going to be efficacious in addition to being safe. We've talked a little bit about an alternative version of a vitamin K antagonist, something called tecarfarin, which may be particularly exciting for people with chronic renal insufficiency, but we're going to need more data about efficacy to know whether or not that's going to be an option in the future. And we may think about different ways of measuring and monitoring warfarin. Think about using the factor 2 and 10 version or the fixed version of the INR rather than the standard PT. Now, I need to make very clear, none of these are commercially available in the United States. As far as I'm aware, they're also not available anywhere in Canada or elsewhere in North America. But there's certainly a lot of excitement about all three of these options. And so I'll encourage you to stay tuned as these various approaches and agents continue to develop. Thanks so much, Arthur, and I'll turn it back to you.
All right, thanks, Jeff. Wow, another great presentation. So a lot of this was presented at AC Forum for the new agents, but we had some new talk here about the fixed testing and that kind of thing that's really hot off the press. Is very exciting. I want to bring in Gene Connors as our panelist. Gene has been involved in kind of strategizing with some of the newer agents and kind of thinking about their use and practice and that kind of thing. Gene, I'd like just to get kind of your summation, if you will, kind of talk about what Jeff mentioned and kind of what you can see coming and kind of predict.
Yeah, well, thanks, Arthur. And Jeff, that was an amazing presentation. And I really share your excitement about what's coming down the road. I think this is a great time to be involved in anticoagulation. And I think everybody in this webinar has some sort of hand in anticoagulation, whether it be management, stewardship, patient care. And like your case pointed out, we all recognize that despite the significant advancement of DOACs, we need other strategies for these patients. And I think that's where the excitement comes in. I get asked a lot of time about, the DOACs. The DOAC are really good. And that's one of the things when we look at the Oceanic AF trial that was halted early, right? I mean, the event rate was 1%, 1 per 100 patient years, right? So it's going to be hard to beat that. But for patients who have increased risk of bleeding, I think the factor 11 inhibitors, maybe tecarfarin with better management, we really need to see. And I look forward to seeing this data. I think the question I also get asked is one of, well, we have these great drugs. We have DOAC. We have a choice now compared to just warfarin alone or the daily injections with, enoxaparin or fondaparinux. Why do we need factor 11 inhibitors? And your case really nicely, I think, portrays that. Whether they've got renal disease, whether they've got labile INRs, whether they've got cancer and an increased risk of bleeding, all of those patients need something better than we have right now to try to minimize bleeding. So I think that from my backyard, the DOACs kind of had a slow uptake here in the Boston area, and it took a while for people to really want to use them in practice. And I think we're going to see if the phase 3 trials are successful and they give us the promise of similar efficacy that we will see a much more rapid uptake. And I think that's the crux, though. Whenever we design a clinical trial, we talk about the non-inferiority margin, right? Because we're not going for superior efficacy, we're going for similar, and how much we're willing to tolerate and maybe a little increased risk of stroke, but dramatic decrease in bleeding. I think that's really where our input and our collective experience after the phase 3 trials come out and real world data are going to be needed.
Yeah, absolutely. I think that there's just higher burden of proof with these drugs overall. And, as I've thought about it, I've thought, well, gosh, we've got good drugs with relatively low rates of adverse events, even compared to warfarin that are going generic. The burden of proof that I should use this. But as you bring up a really good point, and I'm kind of harking back to the bridging trials where we're like, gosh, you would have to have so many patients to have enough thromboembolic events to show a difference. So even really the burden of proof in these trials, it's easy kind of on the surface to say, well, gosh, this trial was stopped early, and they don't seem to be reducing events. But the burden of proof is something really to keep in mind, I think.
Well, Arthur, I want to add to that because, and as you discussed, I'm involved on some steering committees for factor 11 inhibitors and some data safety monitoring boards. The milvexian AFib trial, the Librexia AF trial, has completed enrollment of over 21,000 participants. So when we talk about the numbers needed to prove, hopefully that will give us a definitive answer, but it also can be reassuring, no matter what the answer, that enough patients were studied. And I just have to say, those of us in hematology would never see a patient population of that magnitude. You cardiologists are lucky to be able to prove that.
Yeah, it's so interesting. I think back to, what made warfarin the standard of care for atrial fibrillation, a trial of roughly 300 patients. The
Yeah.
DOACs trials, thousands of patients, and now we're going to have to see even, massive numbers of patients, even more so. So one of the things that has come with these newer agents is better science, to be honest. We've seen with these new trials, they've
Absolutely.
answered questions that we haven't been able to answer historically. So it's been exciting to live. So Jory, let me jump to you. You're helping out with the Q&A, and love to see what kind of questions we have coming in, or what we may have had pre-submitted.
Sure. I'm like typing furiously to try and catch up because these are all wonderful questions, but a lot of interest in tecarfarin. So I think a lot of us deal with warfarin in our practice. And so the idea of something that's similar but slightly different, but maybe based on some of the things that we're comfortable with, sounds really appealing. And so I wonder if we could speak a little bit more about what we know. What is the side effect profile? Do we have same dietary restrictions? How do we reverse these agents? If you could speak a little bit on kind of the logistics of what that might look like for our anticoagulation providers, I think that'd be really helpful.
Yeah, Jory, I'm happy to start. And then, Gene, I might ask you to comment because I know you've been involved over time with some of these. And the first thing I'm going to say is there's a lot more we need to learn. I mean, think about warfarin we have been using for decades and decades. And tecarfarin, while it has been out for about 10 years or so, it's been very limited, only in a couple small trials. And so we don't have a lot of those practical day-to-day management things. But it is still a vitamin K antagonist, which means it still works by the same mechanism, right? It's inhibiting vitamin K's ability to produce the different clotting factors. And so, yes, foods that include or don't include vitamin K are going to have some impact on it. Yes, administration of vitamin K is a way to sort of overcome the effects of tecarfarin, but all of the other sort of day-to-day practical questions are things that would need to really be investigated more once this sort of develops further. And I think that's the big question. Right now, it's where might this be a good fit? And then let's test it in some of those populations. If it's shown to be efficacious and safe, as it would seem it might be, then you sort of move forward to say, okay, what might it look like from a routine clinical practice standpoint? Gene, anything that you would add to that?
No, I think you summed it up very nicely, Jeff. I think, kind of like the fixed test, we're looking for something with a little more stability and less drug-drug interaction and food interaction and alcohol and all of that. And tecarfarin, appears to promise that, but as we know, the proof is in the pudding. And to Arthur's point, I've seen an evolution just with the DOAC trials with warfarin as the comparator in the attention to warfarin management, right? And so, in the past, no one even knew what TTR was, right? And now we have, thanks to Fritz Rosendahl and others, some great measurements of how much time in range people are spending. And the proof is going to be in further data, sort of demonstrating. And this is going to be the tricky part, because I'm sitting here thinking, well, how would you design a trial, right? Would it be tecarfarin versus warfarin? And what are you going to look at, right? Are we going to, because as Jeff, nicely pointed out and detailed, it works the same way. It's a vitamin K antagonist, right? The issue is that the variability and the lability that we see with warfarin metabolism may be less with tecarfarin. And how are we going to prove that, right? Is it fewer INRs? Is it, fewer bleeds, we hope? Is it fewer thrombotic events? But it's going to be interesting again. And I look forward to seeing the data that come out of any trials that may be forthcoming. Again, warfarin, I think, Arthur, it's been around since 1950, right? No one really paid that much attention to it. It is very inexpensive when you're looking at drug cost. We all know that the monitoring is expensive. And so again, how we trade off those benefits is going to be, I think, interesting and maybe a bit of a challenge, but if it's safer for our patients, that's where we need to go.
Yeah, so I mean, back to the whole burden of proof issue. Like trying to roll out, a new vitamin K antagonist in a DOAC world. They have to be very kind of strategic about where is it going to be used. Let's be realistic about where it would be used, where it competes, if you will, in the market. One of the things I've said for years is, in a DOAC world, we have to make vitamin K antagonists less of cruel and unusual punishment. And how do we do that? Is it with a better agent? Is it with a better test? Is it with patient self-testing? Is it with patient self-monitoring? What can we do to make vitamin K antagonist therapy seem like less of cruel and unusual punishment?
Yeah, that's a great point. I do have to say that when the DOAC did start coming out and were taken up, the headlines were death of warfarin disappears. Warfarin hasn't gone away. And I think we're still going to have the need for those populations to continue with warfarin. We're talking about efficacy of 11 inhibitors. Are they going to be sufficient for mechanical valves, where we know the DOAC failed spectacularly, right? Or valvular AF? I think the answer is probably not. We're still going to need warfarin for those patients. So something better and something, as you said, less life sentencing, cruel and unusual punishment. I love that, Arthur.
Yeah, you guys can use that. I won't. No question. All right, we're gonna kick it over now to Gabe Fontaine. Let's hear about what he has for us, and we'll come back and chat after his discussion.
Awesome. Thanks so much, Arthur. Let me share my screen here. Just 1 second.
The longer you wait to share, the more I have to stare at that fabulous head of hairs and get jealous.
Thanks, Arthur. Are you seeing it now?
No, it's not up yet.
Okay.
There you go. Thank you.
How are we looking? All right. All right. Well, thanks so much. I'm Gabe Fontaine from Intermountain Health. It's an absolute pleasure to be able to follow Jeff's fabulous presentation, be a part of this panel. My part of the talk today is going to be on emerging reversal agents. What's next in the pipeline? Here are my disclosures. Similar to Jeff, it's a lot of the anticoagulation space as well as neurosciences, and I'm also on the board of the Anticoagulation Forum. Our objectives for the next 10-ish minutes are to identify emerging antithrombotic reversal agents, describe the mechanisms of action, and then critically evaluate primary literature. So the two main agents we're going to be talking through today are saroparentag, which is on the left-hand side, and bintracimab. Saroparentag is a small ionic molecule, as you see there depicted on the left-hand side, and it was very intentionally designed with multiple binding points to medications in the DOAC spectrum, whether it be factor Xa inhibitors, direct thrombin inhibitors, oral as well as parenteral agents, as well as our heparinoids, so our unfractionated heparin and low molecular weight heparin. And you'll see just how effective this molecule is in binding and reducing anticoagulation in the myriad anticoagulants we have available to us. On the right-hand side is bintracimab. This is a very specifically designed monoclonal antibody to ticagrelor. And so we'll dive into some of the data there as well. First is saroparentag. On the left-hand side, you see this very medically sound, scientifically sound depiction of how saroparentag can bind to multiple agents. So for our factor Xa inhibitors, the very specific binder and inhibitor is, of course, indexinate alpha. This is a monoclonal antibody, or excuse me, a recombinant factor Xa molecule that binds up our factor Xa inhibitors. With very high specificity, but it's specific to our factor Xa inhibitors, where saroparentag, part of its ionic binding, can bind to apixaban, rivaroxaban, edoxaban, and even fundaparinux. And then on the right-hand side of that graphic, we see it binding to dabigatran. Now, of course, dabigatran already has a reversal agent. It's the monoclonal antibody idarucizumab, or Praxbind. But of course, that is a molecule designed to inhibit or bind up a specific agent, and that is dabigatran, where saroparentag, with these multiple binding points, is able to bind not only the factor Xa inhibitors, both parenteral as well as enteral, but also the direct thrombin inhibitor dabigatran. Now, some of the early studies of saroparentag's ability to reduce bleeding was conducted, obviously, in animal models. This is where we start all of our phase 1, then progressing into phase 2 studies. And depicted here are some initial phase 1 studies looking at saroparentag's ability to reduce bleeding. Now, I'll walk you through this graphic. So this is a rat model of either tail or liver resection and the amount of blood that occurs after that injury. And so on the top left in the A box, we see saroparentag given at various doses after this rat blood has been loaded with edoxaban, a very high dose of 60 milligrams per kilogram. And you see that with increasing doses of saroparentag in that top left-hand corner, going from red to purple to darker purple to orange. We see that with increasing doses, we get reduced blood loss in this rat model. In the top right-hand side, we see the same sort of study, but this time over time intervals. So on the left-hand side, we have 0 to 7.5 minutes, and then on the right-hand side, we have 7.5 to 15 minutes. And we see that in the edoxaban-treated rats, of course, that bleeding amount goes down over time, but it's substantially and statistically decreased in our reversal. And then obviously it's quite low in the no edoxaban group. Saroparentag is so effective in this bleeding model that it actually mimics rats that had received no edoxaban whatsoever. On the bottom left-hand side in our C graphic, we see this is a post-injury model, whereas the previous two were pre-injury models. So this is the amount of blood loss after the tail is resected and then the saroparentag is administered. And then on the right-hand bottom part of that D graphic, this is with dabigatran, and we see very similar outcomes here. So whether it's edoxaban or dabigatran. And then these same exact studies were conducted in other anticoagulants. And so in the top left, that E graphic, this is the same exact study done with apixaban, and we see that with both the medium and high dose of saroparentag in the red and green blocks respectively, we get a rapid reduction of the amount of blood loss in the rat tail model. And then in the top right, the F block, we see this same exact outcome in rivaroxaban. And then this is where it gets really interesting. Aside from our DOACs in the G and H blocks, we see a rapid reduction in the amount of bleeding in our unfractionated heparin group, even compared to the unfractionated heparin group receiving protamine, which is more or less a standard of care for reversing unfractionated heparin, and very similar outcomes in the bottom right, or the H block with enoxaparin, our low molecular weight heparin. We see a significant reduction in the amount of blood loss with the Seraparentag group, way more than the blood loss, way less, I guess, than the blood loss in the rats treated with protamine. So where does this progress? Those were our phase 1 studies. Well, phase 2 studies have actually been ongoing for quite some time now. This was the only trial in clinicaltrials.gov that comes up in human subjects or healthy adults. And in this study, these healthy subjects were loaded with these various doses of edoxaban, apixaban, and rivaroxaban for 4 days. And essentially, Seraparentag or placebo, which was just NS placebo, was administered at peak concentrations of these agents. So patients would have received edoxaban, apixaban, or rivaroxaban for 4 days, and then at roughly peak dose, or approximately 4 hours after their last dose of edoxaban, apixaban, or rivaroxaban, they would have been randomized to receive either Seraparentag or placebo. And the primary outcome of this study was whole blood clotting as measured with this Perispheres technology coagulometer device. This study actually just concluded at the end of 2024. And so we're really hoping for readouts and publications of this evidence, and then eventually progression, we hope, to phase 3 trials. Seraparentag really offers us the opportunity to use a more or less universal reversal agent, one that can bind to factor 10A inhibitors, whether oral or parenteral, one that can bind to direct thrombin inhibitors, and one that can bind to and reverse unfractionated heparin and enoxaparin to a greater extent than with protamine. So it really is a great opportunity, and more studies to come. Now, shifting gears to bintrafimab, and before I embark on this brief journey, I do want to give great thanks to Dr. Deepak Bhatt and his colleagues. Dr. Bhatt is the primary investigator of many of the bintrafimab phase 2 and phase 3 studies. And a lot of the data that I'll present here was actually just read out and presented at ACC 25 at the end of March in Chicago. And Dr. Bhatt was gracious enough to share those slides. So a lot of the information shared here will be unpublished, non-peer-reviewed data, but top-line readouts of the REVERSE-IT trial. So before we dive into that, what is bintrafimab? Bintrafimab is a monoclonal antibody, hence the mab at the end of the name. But first, let's go through a little platelet physiology. So the P2Y12 receptor is activated by adenosine diphosphate, or ADP. And on platelets, ticagrelor reversibly binds to the P2Y12 inhibitor. And reversible is the key here. You don't see reversal agents produced for medications like clopidogrel or prasugrel because those antiplatelets irreversibly bind to the platelets. And therefore, there's never any free drug, or there's very little free drug. With ticagrelor, we have the opportunity to bind it with a monoclonal antibody because it reversibly binds to that P2Y12 receptor, therefore allowing for some free drug in that exchange. Bintrafimab is the recombinant human monoclonal antibody fragment, and it binds that free ticagrelor with high affinity and specificity. This therefore allows adenosine diphosphate to activate platelets while the bintrafimab ticagrelor complex is eliminated from the bloodstream. And here's just another depiction of this monoclonal antibody, bintrafimab, binding to ticagrelor, very specific monoclonal antibody specific to ticagrelor. In our early phase 1 and phase 2 studies, a lot of laboratory data came from these. What you see here depicted in the top right-hand portion of your screen is various doses of bintrafimab depicted in the various colored lines there. But on the left-hand side of your screen of that graphic, we see ticagrelor concentrations. And we see that regardless of the dose of bintrafimab investigated in this phase 1 trial, we get a rapid reduction in ticagrelor concentrations, which equals a rapid increase in the PRU, or platelet reactivity unit. This is a measure of the platelet's ability to do its thing. And we see a very immediate increase in the PRU, or platelet reactivity units, from about between 0 and 25 all the way up to about 200 to 250. And this is sustained for, at least in these phase 1 trials, about 48 hours. So now looking at the phase 2 and phase 3 trials of bintrafimab for ticagrelor reversal in patients is the REVERSE-IT trial. So the first publication of the REVERSE-IT trial was in the initial subset of patients, the first 100 patients. And Of course, laboratory data is necessary to embark on this journey, and the same exact laboratory metrics produced in the phase 1 trials was investigated in the phase 2 and phase 3 reverse it trials. In the top left-hand side, you see the inhibition of PRU analysis, and we see a very rapid and near complete reduction of that inhibition of PRU. And then similarly in B, C, and D, this is all to say, without going into great detail, that almost immediately within 5 to 10 minutes, we get a rapid reversal of the ticagrelor effects and a rapid increase in the platelet reactivity units. And that's sustained for an extended period of time, up to 72 hours in this trial. So what exactly was the reverse it trial? So the reverse it trial was a single arm, open label, multi-center trial. Patients were introduced into this trial if they either had the need for an emergent surgery or had active, major, or life-threatening bleeds and had taken their ticagrelor within the previous 3 days. Patients were screened and then obviously included or excluded, and then had an initial baseline verify now. This is our P2Y12 test, or PRU. And then they also had that same test, the verify now, on days 1, 3, 7, and 35. And that was the primary outcome. We wanted inhibition of P2Y12 reactivity units, or PRU, over the first 4 hours was the primary outcome. But there was very important secondary outcomes, and these are our patient important outcomes, as I like to call them. These are clinically significant events. This is hemostatic efficacy of this agent, bentrasimab, in patients either going to emergent surgery or requiring emergent reversal for life-threatening bleeding. And what you see here is a rapid or robust decrease in the increase in the PRU, and that was regardless of any subpopulation. You want as far left of the line as possible. But more importantly, in my opinion, is achieving effective hemostasis. And you want these numbers to be as far right of the line as possible, towards that 100%. And you see that regardless of the subgroup, we had very effective hemostasis as adjudicated with blinded members of the study team. But the one key carve out here is most of these patients, 113 of them, had received surgery, whereas only 9 had had bleeding. And so that's where we dive into what was just presented at ACC a little over a month and a half ago. This is the full data set of all 226 patients, whereas previously it was only 100. And we see with the PRU, a rapid increase of those platelet reactivity units. And this is just looking at all of the different subgroups. No need to go into great detail here, but very effective at increasing PRU in these patients. How about efficacy? What I want to point your eyes to is on the right-hand side of the screen. In the previous publication of Reverse It, on only about 100 patients, only 9 total patients had major bleeding, which was a big downside to that study. Here we see 71 enriched population of major bleeding patients. And we see hemostatic efficacy, that's the call out number in the bright blue, 94% in the overall group, 100% in the surgical group, and 83% in the major bleeding group. And then on the very bottom, important in my space in neurocritical care and stroke, 80% effective hemostasis in our intracranial hemorrhage patients. And here's the subgroup analysis of effective hemostasis. And we see that regardless of subgroup, unless there were exceedingly low numbers, we had effective hemostasis across the board with the bentrasimab treated patients who had received ticagrelor. So in conclusion, bentrasimab significantly restored platelet function and did so rapidly. Hemostasis was effective in the majority of cases. There were no serious allergic, thrombotic, or other events in these phase 2 and phase 3 trials, Reverse It trials. And it appears to be a very promising option for ticagrelor reversal. FDA did grant it an orphan drug designation. So overall, review, seraparentag is a small ionic molecule very intentionally designed to be able to bind factor Xa inhibitors, direct thrombin inhibitors, and our heparin medications, unfractionated and low molecular weight. It quickly and effectively reverses these agents, and there are human studies ongoing. And then bentrasimab just gave you a nice high-level overview of the recently released data yet to be peer-reviewed or published, showing that bentrasimab very quickly and effectively reduces ticagrelor concentrations, increases platelet activity, and shows effective hemostasis across the spectrum of subgroups, including in those with major life-threatening bleeding and including those with intracerebral hemorrhage. And this is pending FDA approval. We hope to have an approval perhaps in the next year or so. So that's all for my portion of the talk. I'll flip it back over to you, Arthur. Thank you so much.
All right, thank you. If we have all the panelists come back on, you can stop sharing your slides. Yeah, going back to you, Gene, I want to get your kind of, if you have 60 seconds or so, just your thoughts in this space, what was just presented, as well as kind of what you see happening in the field in your world.
Yeah, no, again, wonderful presentation, Gabe. Very mechanistic, but also full of data. And Arthur, I think, you know, as we touched on in the first half with Jeff's presentation, the DOAC are here and they're not, you know, going away. And let's make sure we can reverse those. Siraparentag has lots of promise. The one reason it hasn't made its way out yet is because when you put it into the test tube, you can no longer run your standard clinical lab assays. You can't run a PT, you can't run a PTT, you can't run some coag factor tests. So the company is working on a device to, you know, the clot check device, which is like a point of care assessment of degree of anticoagulation. And I think that's really going to be needed in order to bring that to care. I absolutely, you know, all of us who manage patients, you know, perioperatively, right? The idea that you have to stop a P2Y12 inhibitor, you know, days in advance, or they show up and they're bleeding in your ICU. And we have that study, which again is a bit controversial, about how transfusing platelets to these patients doesn't help. And particularly because ticagrelor is a reversible agent. So if you transfuse patients to someone with ICH on a P2Y12 inhibitor and TICAG is moving from the patient's platelet to the transfused platelet, you're going to end up with the same effect. So I think that ventracimab is going to be a game changer for those patients who are on it and come in with bleeding or come in requiring urgent and major surgery. And we see in those types of, the need for a P2Y12 inhibitor tends to go in hand, and Jeff, you could comment on this, with those vasculopaths, right? They've got aortic aneurysms, they've got something where they require some sort of urgent surgery. You know, Jeff, I don't know if you want to comment on that.
Yeah, no, you're absolutely right. And as we talked about, right, the purpose of ventracimab is really to reverse ticagrelor, which has been one of our more potent and newer P2Y12s. But as that starts to go generic, we may start to see increasing use of that agent as compared to clopidogrel, which means that there'll be more opportunity for bleeding related issues, urgent surgical related issues. And so having a reversal agent for what we anticipate will be an increasingly used agent in ticagrelor will be really important.
And for the hematologist, Jeff, the difference between clopidogrel and ticagrelor has to do with prodrug versus active drug and metabolism. Am I right?
Yep. So clopidogrel is the prodrug, so it requires that activation, which is why we often have to load it. Ticagrelor is immediately effective. Ticagrelor is also that reversible agent. So as you mentioned, it can release off of the platelet and move away. And so those are two of the differences. Right now, ticagrelor is primarily used in the setting of an ST elevation MI or an acute coronary syndrome, whereas clopidogrel tends to be more for the chronic coronary syndromes where stents are being placed for angina. But I think we're going to see some movement in that space over the next couple of years.
Yeah, I always get asked, and I'm not the expert in that, you know, oh, should we do, you know, genetic testing for clopidogrel metabolism? I'm like, so
whole separate webinar on that.
I think from that perspective, right? I think TICAG may
be a good option here. So.
Absolutely.
Yeah, for sure. I'd really like to dig into this into this talk, because there's a lot to consider with ticagrelor reversal. But I wanted to ask Gabe, as part of your presentation at the Anticoagulation Forum, we had a question submitted about this. You talked about the different, if we go back kind of the standard available agents for DOAC reversal and DEXA, PCC, you talked a bit about the differences between PCC and really opened my eyes about the content, and in fact some heparin in there. Can you just give us like a minute on the high level issues with the available agents and things that may make the studies and what we see in the news not there may be more to the story, if you will?
Yeah, it's a good question, and I'll try to be brief here. So I think the first and biggest point I want to make is when we say PCCs, 4-factor PCCs, That's really a class of drugs. It's not a single drug, right? And we really need to identify the different components of our different PCCs. And the most notable example, we just had a second 4-factor PCC approved in the United States. Historically, we've only had Kcentra, which is marketed elsewhere as Baraplex. We just had Valfaxar approved in the United States, which is marketed elsewhere as Octaplex. Now, just looking at the heparin contents of these two 4-factor PCCs, and I think the pinnacle reason why we can't lump them all together is Kcentra has somewhere in the dozens of units of heparin in a 1,000 to 5,000 unit dose. Doses typical of sort of reversal. Whereas Valfaxar, for a 5,000 unit dose, can have anywhere between 800 units of heparin, which is not nothing, but it's sort of on the lower side, all the way up to about 4,000 units of heparin. So just wrap your head around that. A 5,000 unit dose of Valfaxar has 4,000 units of heparin. And this is a medication that we're potentially using to produce hemostasis in the setting of factor 10A inhibitors. And this is the last thing I'll say, there are basic science studies showing that when Valfaxar Octaplex is administered to reverse rivaroxaban or apixaban, that it actually does not produce thrombin in those studies.
Yeah, there's a lot to consider there, and I wish that we had time to dig in. We are out of time. Thank you so much for doing that. I want to thank our panel, as you just saw on the previous slide. Thank you to Jory, my co-moderator, to Jeff, to Gabe for their presentations, and to Jean for the serving as a panelist. And I really want to highlight that for those of you who are unable to join us in DC at the AC Forum meeting, what you just saw were basically Cliff's Notes versions of talks that both Jeff and Gabe gave. Their full talks are now available as part of bundles that are available to buy. And if you go and if you buy those bundles, you basically have the ability to see the other talks in that bundle, 4 or 5 talks. We have slides on that, Amanda, right? Yeah, so we have oh wait, they must have gotten taken out. Sorry. So we have some bundles available of talks, and they're being sold for $49 a piece, or if you get, I believe, 5 for $199, if I saw that correctly. And I would highly encourage you, if you want to hear more of Jeff's talk, you want to hear more of Gabe's talk and associated talks in those settings, I would definitely highlight those bundles now being sold. We also have, this is really kind of all part of a newer rollout of AC University, where we have bundles from the conferences. We have on-demand boot camps. We have the CARE and AFVT learning series as well. And then if we could go back to the previous slide there, Amanda, I also want to highlight that Jeff's going to be presenting with Ryan Gow on Medicare's new era. New Medicare formulary changes will affect the cardiovascular drug access and cost. Webinar on June 27th, a partnership to advance cardiovascular health. So look forward for that upcoming webinar. Any other slides, or we get through them all? All right. So thank you all for your time. I appreciate the opportunity, and we'll see you on the next one. Don't forget about the CE.